Hi guys, welcome to Doc Stream. I am a second year MBBS student trying to make your life a little easier for all the confused, stressed, sleep deprived freshers out there. Here you will find simple explanation, quick tips, memory hacks and the things I wish someone told me when I was drowning in anatomy, physio, biochem. I teach, you learn, we panic together. So let's get started. Today I am going to teach you the most frequently asked case-based questions on upper limb and special note to Pondicherry University students. These I have picked up from Pondicherry University questions. These are most frequently asked high yield questions. Even if you are from another university, I suggest you watch it because these contains most important topics. Come on, let's start. A 45-year-old woman came to surgeon with complaints of hard painless lump in upper outer quadrant of right breast. Examination revealed enlarged axillary lymph node on right side and loss of mobility of breast. X-ray of vertebral column showed irregular shadows in bodies of L4, L5 vertebra. What is the probable diagnosis? So whenever you come across these type of question, they most common to they would give is lump. What is a lump? Lump is abnormal mass or thickening of breast tissue. And another clue they give is enlarged axillary lymph node. Another clue you have is mobility of breast is lost. Sometimes they can also give about the retraction of nipple. They can give about retraction of skin, or they can give about Purdy-Orange syndrome. Okay, these are all suggestive of breast cancer. Sometimes they might also expect you to write the side on which it occurs. So here they have clearly mentioned it as right side. So remember to include that also. So name the muscles related to base of mammary gland. Whenever you think of breast, where it is located on top of this muscle. You will all be able to answer, that is pectoralis major. So you have three muscles, in that one you have identified. Other two muscles you can just remember with the mnemonic breast itself. So you can write breast like this, right? Here E stands for external oblique and AS stands for serratus anterior. So you have completed with three muscles. Now let's go in detail about the blood supply and lymphatic drainage. Whenever they ask for blood supply, remember not only to write about arterial supply, you should also write about venous drainage. This is the most common mistake. When I studied first year, I did this mistake. I wrote only arterial supply and most of my friends did too. So I'm making it earlier to you that you have to write both arterial and venous drainage. So let's look. So we have a mnemonic AIP. A stands for axillary artery, I stands for internal mammary artery, P stands for posterior intercostal artery. Whenever you are writing for venous drainage, just write axillary vein, internal mammary vein and posterior intercostal vein. So remember this mnemonic and it is very useful. So see, you have subclavian vein here and it is continuing as axillary artery. So you have axillary artery supply here and you have supply of internal mammary artery, which is a branch of subclavian artery. This supplies the second, third, fourth intercostal space, and here you have branches of posterior intercostal artery. From axillary artery we have three branches supplying. Okay, three branches are, see, you have superior thoracic artery supplying, you have thoracoacromial artery and its pectoral branch is supplying. Thoracoacromial artery is pectoral branch and you have lateral thoracic artery. Most of blood supply to breast is derived from lateral thoracic artery. It is very important, please do remember. And now we have venous drainage. Same, you have the axillary vein, you have the internal mammary vein, and from here you will have posterior intercostal vein. Here we have one clinical significance. Okay, from breast cancer can spread to brain, not via venous drainage. It is not that breast cancer can only spread through lymphatic drainage, it can also spread through venous drainage. So cancer from breast, it can travel to posterior intercostal vein. From there it can go to vertebral venous plexus. From there it can go to intracranial dural venous sinus, and then it can spread to brain. So it is very important, please to remember this. This is the applied aspect here. and you have anastomotic venous circle at the base of nipple, that is called venous plexus of Haller. Okay, base of nipple you have anastomotic venous circle, that is venous plexus of Haller. You have to write about this also. And here you have about lymphatic drainage. This is lymphatic drainage. Here it has two, lymph nodes and lymphatics. So first let's see about the lymph nodes. So the main is axillary group of lymph nodes. You know this three. This is what you read in arterial and venous drainage, right? Axillary, internal mammary, and posterior intercostal. So in axillary, you further have anterior group, posterior group, central, lateral, and apical. This anterior group is in pectoral region, hence it is also called as pectoral, and posterior group lies along the subscapular vein of axillary, that is that goes and drains into axillary vein. So this posterior group is also known as subscapular group. And lateral, it is present on the humerus, right? Like in humerus it is present. So here you have the axillary vein. Lateral group is present along the axillary vein and it is present in humerus, and this is lateral group. And you have central and apical group. This is what you have axilla here. So you can say that central group is located at base of axilla and apical group is present at the apex of axilla. Is it right? Then you have all these lymph nodes draining the outer quadrant. See, you can divide the breast into 4 quadrants, like it is lateral, medial with this, and you can divide it into upper, lower with this. So outer quadrant of breast is drained by these axillary group of lymph nodes. So after draining, like anterior group, posterior group and lateral group will go and drain into central group. From central group it will go to apical group. From apical it will reach the supraclavicular lymph nodes. So you have supraclavicular lymph nodes here. You have deltopectoral node that is located in the deltopectoral groove. So in deltopectoral groove you have deltopectoral node plus cephalic vein. Okay, cephalic vein. And you have posterior intercostal node here. So you can just say by the diagram it drains the lower lateral compartment of breast, and you have internal mammary nodes that drains the medial quadrant of breast. Let's go into lymphatics. You have superficial lymphatics and you have leap lymphatics. Okay, this superficial lymphatics drains the skin of breast except nipple and areola. Okay, remember it drains the skin of breast except nipple and areola. Deep lymphatics drains the parenchyma of breast along with the skin of nipple and areola. Beneath areola, you have a lymphatic plexus that is known as subareolar plexus of Sapi. It will drain lymph from here and it will go and drain into anterior group of axillary lymph nodes. So you have known about all these things. So you just have to know which quadrant drains where. So I said you have medial, lateral, and you have upper, lower. This lateral compartment drains into axillary group of lymph nodes. Medial compartment drains into internal mammary nodes. And here you have the lower lateral compartment that drains into posterior intercostal nodes. And you have lower medial compartment. Here you have diaphragm. Beneath diaphragm you have subdiaphragmatic plexus. Here you will have abdomen. So you will have subperitoneal plexus. So it will drain into subdiaphragmatic and subperitoneal plexus. From there it will travel to ovary and it will settle there and form a tumor there. So this is metastasis, right? So this path of migration is called transcoelomic migration. Okay, it is transcoelomic migration. And this tumor that has formed in ovary is called Krukenberg's tumor. Okay, Krukenberg's tumor. So till now you have learnt about 2 clinical significance. One is via venous drainage and one is via lymphatic drainage, and one more you have. See, usually they would say breast malignancies are bilateral. Have you ever wondered why? Because lymphatic drainage from one breast travel to other via internal mammary nodes. via internal mammary nodes, it spreads to other side. And if they ask it is superficial lymphatics or deep lymphatics, it is superficial lymphatics. Please do remember that. And the last question, what is the reason for irregular shadows in X-ray in this patient? It is because of the cancer has metastasis. That is the answer for this question. And now let's move on to the next question. A 50-year-old female had enlarged right axillary lymph nodes. Examination of right breast revealed a stony hard swelling on upper outer quadrant fixed to the underlying muscle. Here they have also said about swelling, that they just say about the lump here. They also given, they have enlarged right axillary lymph node, and they also have said it is fixed. What are all I explained in the first question, all the clues they have given. So without fear you can write about breast cancer, and the side is right side. Which group of axillary lymph nodes will be enlarged? Here I forgot to tell one thing. See, if we have learned about the lymphatic drainage. In this, if you see, the 75% of lymphatic drainage goes for axillary lymph nodes, and 20% goes for internal mammary, and the rest 5% goes for posterior intercostal. And in axillary, which is draining the most is anterior group. Please do remember this. So here they have asked which group of axillary lymph nodes will be enlarged, that is anterior. And why? They have asked why, because it drains the upper outer quadrant of breast. They have said that they have seen a swelling here. Most commonly this quadrant is affected, and this quadrant drains where? It mostly goes for anterior aspect. Here I also missed one thing. See, you have the anterior group, posterior group, lateral group draining into central. From there it goes for apical group. Apical group can also receive lymph directly from deeper aspect of breast also. So here you have anterior group of lymph nodes draining the upper outer quadrant of breast, and that's why it is mostly enlarged. Which group of axillary? That is anterior, and I have explained the reason. Mention other groups of lymph nodes draining the affected, which are this you have already learned. How does subcutaneous lymph edema present and why? Subcutaneous lymphedema present as swelling or a feeling of heaviness, tightness, and skin changes will be like the changes in Pew-de-Orange syndrome. I hope you all read about the Pew-de-Orange syndrome in that, and why they have asked. I said Pew-de-Orange syndrome, so you can say directly say why. Why is lymph? Basically a swelling is there because the fluids are getting accumulated there. Why the fluids are getting accumulated? These are getting accumulated because due to obstruction of lymphatics. That's why it is happening. Since I have said Pew-de-Orange syndrome as skin changes, you can write obstruction of superficial lymphatics. What type of gland is affected structure? When we classify glands based on many things, and one thing we are going to talk about here is secretion. How the gland secretes. Based on the secretion, it is classified into, glands are classified into merocrine, apocrine, and holocrine. Merocrine glands, they secrete by exocytosis, and holocrine gland, the whole cell disintegrates. And in apocrine gland, they secrete by shedding the apical portion of glands and their products. So we can now say the breast is modified apocrine gland. Okay, we have got the answer for all these questions. Let's go for next question. A patient was diagnosed with inferior dislocation of humerus in X-ray of shoulder joint after an injury. On examination, there was sensory loss on skin covering lower aspect of deltoid, inability to do abduction of shoulder, rounder contour of shoulder is lost. See, what structure will be damaged in inferior dislocation of humerus? They have said here, they have given a clue here that sensory loss over deltoid is lost and inability to abduct the shoulder. If you see, which will help in abduction of shoulder, mostly it is deltoid middle fibers. Okay, deltoid middle fibers helps in the abduction of shoulder. Okay, it is the most major one, most important one in the abduction of shoulder. If it is not there, you will not be able to abduct. So you have to now know which nerve supplies deltoid. Which nerve supplies deltoid? If you see, it is axillary nerve. So which structure is affected here? Axillary nerve is affected. What are the muscles supplied by it and what are their actions? You know, here I have said one muscle, that is deltoid, and another muscle is teres minor. Okay, one muscle is deltoid, another muscle is teres minor. These both muscles are supplied by axillary nerve. So if you see deltoid, again deltoid can be divided into, you can divide it like this, or you can divide it into upper anterior fibers, middle fibers and posterior fibers. I said middle fibers is for abduction. Then anterior fibers does the flexion part and medial rotation. The posterior fibers does the extension part and medial rotation. Teres minor is for the lateral rotation of arm. And now they have asked why there is sensory loss. See, this axillary nerve continues as upper lateral cutaneous nerve of arm. Upper lateral cutaneous nerve of arm. So there is sensory loss on skin covering lower part of deltoid muscle. Mention the boundaries of space through which the structure passes to leave the axilla and its accompanying structure. You have the quadrangular space. Quadrangular space is the one through which axillary nerve passes. Along with axillary nerve, you have the posterior circumflex humeral artery accompanying. So if they ask about the boundary, the superior boundary, this muscle that it is cut, this muscle is teres minor. So superior boundary is teres minor. If you see inferior, that is coming from inferior angle of scapula somewhere here. So this is teres major. So teres minor superior boundary, teres major inferior boundary. And you have medial lateral. So medially you have muscle going and attaching to back side of humerus. What is the muscle that is present on back side of humerus? That is head of triceps. So you have long head of triceps here, long head of triceps, and this is medial. So lateral is shaft of humerus. So you have found the boundaries. So teres minor is superior, teres major inferior. Medially you have long head of triceps and laterally you have shaft of humerus. What is special feature of branch of this structure supplying the muscle? It is that it winds around the surgical neck of humerus. See, if you see about, if you take humerus, it has three necks. Okay, one is anatomical neck, another is surgical neck, and another is morphological neck. Morphological neck is one that you cannot see with your naked eye. You have to see in the radiological examination. So let's eliminate this. So anatomical and surgical. So anatomical is that if you see humerus head, it will be like 3/4 of a spear. You will have 3/4 of a spear, and you will have a marking separating it, and it will continue a shaft. This marking, that is saying this is 3/4 of a spear, is anatomical neck. And the surgical neck is the constriction. You have a constriction. This is constriction. The constriction between the shaft and head is called surgical neck of humerus. Okay, so this surgical neck of humerus is wound by a branch of axillary nerve. So this is more important, as see, head is also large, shaft is also large, in middle you have a constricted area, so it is more prone to damage, right? So whenever fracture happens in surgical neck of humerus, axillary nerve is damaged. Also in case of wrongly placed intramuscular injection, wrongly placed IM injection, axillary nerve is damaged. So let's move on to the next question. A 37-year-old woman came to surgeon with complaints of hard painless lump in upper outer quadrant of breast. Examination revealed enlarged axillary lymph node on right side and loss of mobility of affected breast. I guess you can all be able to answer this question. Breast cancer, that is on right side. Write about the extent and mammary breast structure. So extent, whenever you write about the extent, you should mention horizontal extent and vertical extent. Horizontal and vertical extent. Vertically, the breast extends from the second rib to sixth rib. Okay, second to sixth rib. And horizontally, if you see, you have the sternum here, and you have this is suppose imagine this is a body. Here you have sternum, and this is axilla, right? So this is sternum, and this is mid axillary line you will have here, and lateral border of sternum. This is the vertical, this is the horizontal extent. So vertical extent is from second to sixth rib, and the horizontal extent is you have from lateral border of sternum to mid axillary line. Mammary breath structures, already you know about these three muscles. In that, pectoralis major is covered by fascia, pectoral fascia, and retromammaries place. Retromammaries place between the breast and the muscle you have a space that is called retro. See here, you have pectoralis major muscle here, and you have pectoral fascia, and you have a breast here. In between this both you will have some space. This space is called retromammary space. This space contains fat, this loose areolar connective tissue. This only allows the mobility of breast. It allows breast to move up and down, side to side. Okay, we have completed with bed structure. Now lymphatic drainage of mammary gland we have already completed. Applied aspect also we have completed. I said in venous drainage it travels to brain, that you can write, and you can write about the Krukenberg's tumor, how it spreads to ovary. You can write about that. You can also write about retraction of nipple. Retraction of nipple takes place because of fibrosis of suspensory ligament of Cooper. Fibrosis of suspensory ligament of Cooper. You can write this. And you can also write about retraction of skin. These happens because of infiltration. Because of infiltration of suspensory ligament of Cooper. And you can write about the Pudi-Orange syndrome, which is basically an orange peel-like appearance that happens because of obstruction of superficial lymphatics. This also you have already learned. I wanted to say something. Whenever you write about breast cancer on right side, you just give one line explaining where the cancer happens, what happens in that, because it's like whenever you want to aim for distinction, you have to write all this. You can write it arises from epithelial cells. It arises from, okay, arises from epithelial cells. Epithelial cells lining lactiferous ducts or acini of lobules. Okay, we have completed the fourth question. Let's move on to fifth question. A man involved in automobile accident was brought to casualty. On examination, it was found that his left shoulder was flattened and head of humerus was found in infraclavicular fossa. What is the diagnosis? Discuss shoulder joint under following headings. See, they have said it is infraclavicular. So scapula is behind, and you have glenoid cavity here, scapula here. This is humerus, and clavicle you will have in front. It has displaced in infraclavicular, means it has come front of glenoid cavity. It has come front of glenoid cavity, which means it is anterior dislocation of shoulder. And type and articular surfaces. So whenever you just think of shoulder joint, you have one scapula, this is scapula, and you have one humerus. So like type, you will write about it is ball and socket type of synovial joint. Ball and socket type of synovial joint. Articular surfaces, just think, you don't have to mark up. So in scapula you have the glenoid cavity here. So a glenoid cavity is very shallow cavity, so it is deepened by a fibrocartilaginous rim, that is glenoid labrum, and this is located medially. So lateral, what you have, lateral what comes and articulate, head of humerus comes and articulates. That's all. You are completed with articulating surfaces. And you have ligaments. So whenever you write for any joint, whenever you don't know about ligament, you can just write capsular ligament. It surrounds the glenohumeral joint. Whatever joint it is, it surrounds the joint, you can write. And what is the medial lateral attachment? Just if you think of the joint, you will be able to identify. See, it surrounds the glenohumeral joint. This you already know. Now you have to write the attachment, where it attaches medially, where it attaches laterally, where it attaches inferiorly. You have to write. So if you see medially, I have said that glenoid cavity is there, it is deepened by glenoid labrum. So medially it is attached to margins of glenoid cavity behind the labrum. This is what this point you already know. Laterally, where it is attached, see, it is attached to here. You will have the anatomical neck, so it is coming and attaching to anatomical neck of humerus. Now inferiorly, where it is attached, see, inferior you have, see, inferior, I said no, head you have, head is this, shaft is this is the constriction, this is surgical neck of humerus. You can see somewhere beyond, this is can be surgical neck, beyond surgical neck of humerus it is coming and getting attaching. So medially glenoid cavity beyond glenoid labrum, laterally to anatomical neck of humerus, inferiorly it is attaching to surgical neck, beyond the surgical neck. So these are all the attachments you will write. Next you have the glenohumeral ligament. Okay, it is thickening in anterior part of the fibrous capsule. You have three glenohumeral ligaments, that is superior, middle and inferior. See, here you have the superior, here you have the middle and here you have the inferior. This superior one, if you see, it helps in adduction. Okay, superior one helps in adduction, middle one helps in external rotation, and inferior one is the one that helps in abduction and external rotation. Superior is adduction, middle is external rotation and inferior is adduction and external rotation. Okay, if there is a defect in superior and middle glenohumeral ligament, you will have anterior dislocation of shoulder. If you have defect in superior and middle glenohumeral ligament, you will have anterior dislocation of shoulder. Next you have coracohumeral ligament. If you see, from base of coracoid process, it is going and attaching to greater tubercle. Okay, what aspect? Anterior aspect. Okay, so from base of coracoid process, it is going and attaching to greater tubercle of humerus, anterior aspect of greater tubercle of humerus. So this is coracohumeral ligament. Another ligament is transverse humeral ligament. Transverse humerus ligament, it bridges the intertubercular sulcus. Through this sulcus, you will have the long tendon of biceps going. So it bridges the scraps and seals the long head of biceps from coming out. So this is transverse humeral ligament. You also have some accessory ligaments, that is coracoacromial ligament. From coracoid to acromion it is present. So it is coracoacromial ligament. If you see, this is coracoacromial ligament. So coracoid process, acromion process, coracoacromion, together it forms an arch. Coracoacromial arch, therefore it prevents from shoulder joint to come up. So therefore it prevents superior dislocation because it is forming a shield like thing and it prevents it from coming up. So the ligaments are over. Now apply muscles and movements. Okay, in muscles and movements, this is just, you have to think of the muscle, what all it can do. Whenever they ask you, write for movements and the main muscles. You have to compulsorily like this. We have already learnt about, see, deltoid, you have already learnt. Deltoid, anterior fibers, middle fibers, posterior fibers. Anterior fibers helps in flexion and medial rotation. So you can write this, deltoid anterior fibers plus pectoralis major is present in front. So it will help in flexion. Extension is deltoid posterior fibers. This you already know. And you have latissimus dorsi also helping it. Remember, deltoid D, latissimus dorsi D. So extension you will write like this. Okay. Adduction is pectoralis major and latissimus dorsi. When, like, I'm saying how to remember, this is not exact what is happening. Like, you can see here, you can reject deltoid and you can write this both here. Okay, adduction. In abduction you already know. See, in abduction you know the first 0 to 15 degree is brought about by supraspinatus, and then the next 15 to 90 degree is brought about by deltoid middle fibers, and then see, and then scapula has to rotate laterally. Only then you can go above 90 degree. So scapular rotation takes place more than 90 degree, and then which are the muscles that helps is serratus anterior and upper and lower fibers of trapezius helps in overhead abduction. Okay, it helps in overhead abduction. Now, medial rotation. Medial rotation is brought about by one main muscle, that is subscapularis. Please do remember this. Lateral rotation you have already read, that is teres minor helps. Okay, write about teres minor. Applied anatomy. Already you have learned, this question is about anterior dislocation. So this is one of the applied anatomy. So you can write anterior dislocation, and what you have to write, what is the cause of this. So it happens when there is a blow to abducted, externally rotated and extended arm. So this causes anterior dislocation. You can also write about posterior dislocation, and you have to write what happens, like how the clinical feature looks. The humerus is displaced to front of glenoid cavity, that you have to write. In posterior dislocation, the head of humerus moves behind and above glenoid cavity. And what is the cause if they ask? Anteriorly directed shoulder trauma, you can write. And then you can write about the inferior dislocation. Before it was thought that inferior dislocation is most common, but it is not that. Anterior is most common. They have thought inferior is most common because if you see from above, I said this is coracoacromial arch, so it prevents from superior dislocation. You have transverse humeral ligament helping this joint to move laterally. So in medially also you have glenoid cavity, that is deepened by glenoid labrum, and you have the rotator cuff muscles here, that is remembered by the mnemonic sits: supraspinatus, infraspinatus, teres minor and subscapularis, that holds this humerus very tightly and it pulls medially. So if you see, only inferior is defect. So they thought inferior dislocation is most common. And in inferior dislocation, the arm is abducted above the head permanently. And you can write about the painful arc syndrome. If you see here, you have the coracoid process, acromion process, coracoacromial ligament here, and this is supraspinatus tendon, and you have subacromial bursa. Okay, whenever there is deposition of calcium in supraspinatus, it irritates the bursa above it. It irritates the subacromial bursa. So whenever the person raises the arm, whenever he is abducting the arm, whenever the person abducting the arm, the bursa slips here, slips in between both, and there happens subacromial impingement. There happens subacromial impingement. Okay, so whenever the person raises the arm or abducts the arm, he experiences a very severe pain that usually occurs in 60 to 120 degree of abduction, and this is called painful arc syndrome. It is very, very important. It can also be asked as a reasoning question. One more is there, that is Dawburn's sign. Okay, Dawburn's sign. Dawburn's sign is that, see, when the person is adducting the arm and you give pressure here, they will feel the pain. But when the same person is abducting the arm, he is abducting the arm, it will go and slip here. Okay, and that time you give pressure on deltoid, the person will not feel the pain. He is feeling the pain when in adduction position, because it is between deltoid here. That is why when you give pressure, it is getting compressed and you feel the pain. But in abduction, you don't feel the pain because it slips under supraspinatus and coracoacromial arch, and therefore you don't feel the pain. And this is known as Dawburn's signs. This is also a reasoning question. Okay, and at last you know adhesive capsulitis. Adhesive capsulitis is shrinkage of shoulder joint. So whatever you do, you will have some pain. So in what cases you can exclude the shoulder joint diseases is that you can exclude shoulder joint diseases whenever the person is able to abduct the arm, and he can abduct the arm and he can bring down the palms together. So if the person can do this, he can abduct the arm and bring the palms together, you can exclude shoulder joint diseases. Okay, so we have completed the part 1 of this case based question. I will upload the part 2 sooner or later. So if you want me to make any alterations or you have any suggestions, please do comment, and I will answer for your queries. Thank you.